Dr. Raja Shanmugakrishnan has done his DIP&B in plastic surgery at Ganga Hospital, Coimbatore. He is now a consultant oncoplastic breast surgeon and plastic surgeon at Ganga Hospital itself from July 2018. He has trained under various mentors like Professor Venkat Ramakrishnan and Dr. Najib El Mutadi at Chelmsford, UK and Rod Rorick from USA. His special fields of interest are oncoplastic breast surgery, aesthetic breast surgery, rhinoplasty, body contouring, burns, microsurgery and trauma reconstruction. He will be speaking on his experience in the field of oncoplastic breast surgery for plastic surgeons. And to chair this session and add his own experiences in this field, we welcome Dr. Shivra Bharathwaj, the Senior Consultant Plastic Surgeon from Apollo Specialty Hospitals, Chennai. Over to you, Dr. Shivram, sir.
Karthik, at the outset, thanks very much for putting this program together. I know you're taking enormous effort and pain to put everything together, and thank you for getting everybody on board for this. Without much ado, let's just, and once my greetings to the people on the panel today and Senior Plastic Surgeon, Dr. Shivra. Without much ado, we just straight away kick off on Raja's talk, on his experience and his vision for breast reconstruction with reference to the scenario here. And whatever questions anybody wants, please put it on chat. I shall gather them all together and present it to Raja, and if needed and if possible, add on my own 2 bits at the end. Over to you, Raja. Let's start straight away.
Good evening, everyone. I'm just sharing my screen.
Yeah.
Sir, host disabled participants screen.
Yeah, you can share now.
So is my screen on, sir?
Yes, on.
Good evening, everyone. Respected chairpersons, professors, teachers, and my dear friends. I would like to talk today on the field of oncoplastic breast surgery for plastic surgeons. At the outset, I would like to thank GK sir for giving this wonderful opportunity to do this new, interesting, novel topic and the method in which he did it. So this is a screenshot of the WhatsApp that he had just sent. So it's a plastic surgeon who has completed between 5 and 10 years. Incidentally, I'm just 1 month beyond 5 years. And so happy to go on to this new group of bigger boys club. And to make it do it, I would like to present the work that I'm very passionate about. And that is about the oncoplastic breast surgery for plastic surgeons. So if you're going to see the number of plastic surgery seats per year in Tamil Nadu, it is around 36 MCH plastic surgery seats and 6 DNB plastic surgery seats. That makes it around 42 plastic surgery seats per year. And if you're going to add 2 from Jipmer and Pondicherry, in the TANPAPS region, it is around 44 plastic surgery PE seats per year. And if you're going to take it into context with the amount of plastic surgery seats which throughout India, it is 219. So which makes that for 1 in every 5 plastic surgeons are produced in this TANPAPS region. So that means there are a lot of plastic surgeons, but still I feel that the plastic surgery is one of the least competitive fields in medicine because it is very vast. And if you can see what Peter Nelligan has written in his first chapter in his book, he says that in some ways plastic surgeons are the last general surgeons. And so there are so many different subspecialties that we have in plastic surgery, and each subspecialty is now so vast, and the amount of work that we can do in each subspecialty is so much. And so I definitely feel there's a lot of scope for everything. And of all these subspecialties, I would like to talk about one subspecialty, which is the oncoplastic breast surgery, which compared to the rest of this other subspecialty is relatively in its infancy in India. So now what is this field, oncoplastic breast surgery? So from the words itself, it means It deals with the oncological aspects as well as the plastic surgical aspects of the breast. So if you're going to, so it deals with both the oncology as well as the plastic surgery. And in terms of plastic surgery, it could be a reconstructive as well as aesthetic plastic surgery. So why at all this field oncoplastic breast surgery? So if you're going to think and see why this field called oncoplastic breast surgery came, so initially it was breast oncology, and then later on with the advancements in breast oncology, they found that the 5 year the survival rate of breast cancers was quite high. So if it is just localized to the breast, the 5 year survival rate is now 99%. If it goes on to the axilla, it is now 85%, and goes on to distant mids, it's now 27%, and all stages combined, it's around 90%, which is quite high for any cancer. And that's the reason why we are now not only talking about 5 year survival rate, we've also started talking about 10 year survival rate, which is not too common in many cancers. So what is the thing? So now mortality is not the big thing, morbidity is a big thing. So no one can be call us up saying that we saved a patient from breast cancer. Now we need to think in terms of not only mortality, we also need to think in terms of morbidity, because these sort of things can be distressing for a lot of women, because it alters the psychosocial aspects of a lot of women. And this is what we can do achieve, and this is what we can produce good results. So now, what is the scope of this specialty? For a lot of young people over there who are just finishing or just finished, a lot of people may be thinking as to what is the scope of this subspecialty and what can they plan to do. So if you're going to think into the scope of this subspecialty, so if you can see the amount of cancers in the whole of India, if you see the amount of cancers in the whole of India, and this chart talks about the cancers among women in 2018, and breast cancer is the most common cancer with 27.7%, which is just about more than 1/4 of all the tumors. And if you can see both the sexes combined, male and female, although we know that male breast cancers are quite rare, it is around 14%, and with the next one is only oral cancer, which is around 10%. So that means to show that how many breast cancers that we have throughout India. Breast cancer is quite common in India. And you can see the incidence of breast cancer when compared to what it was before. The incidence of breast cancer has been continuously rising up. And interestingly, there are a lot of studies which now states that compared to what it was before, we are seeing a lot more younger people. So when we're seeing a lot more younger people, they have more things about how they look. And now this also comes into phase that we need to make them look better as well. So what are the scopes that we can do? So we can do immediate reconstruction. So if we see a whole breast reconstruction, we can do a whole immediate breast reconstruction where we do a skin sparing mastectomy, and then we do a DIEP. So this is a case of an immediate reconstruction that has been done. And this is a case of a delayed reconstruction where we have done it at a later stage. And then we have used bilateral reconstruction using tuck flaps, which are microsurgical flaps. And you can see that for this is a young lady who had breast cancer when she was just 36 years. Imagine if you had done mastectomy for her, what would have happened? She would have looked like this. That would have looked very difficult for a 36-year-old lady. And now it's not only about whole breast reconstruction, we're also doing a partial breast reconstruction. So you can see that here we have a Phyllodes tumor. You can see the tumor when she was just lying down, and that's the tumor out. And this is the same lady. And you can just see it's just a small incision which is done at the areola skin junction, and there's no other incision elsewhere in the whole of the breast. We have removed the tumor, and then we put up a pedicle LD. There's just one line in the bra line in her back, and one small line in the axilla. And otherwise, she doesn't have anything, and that's the same lady. So we also moved on to other things like other flaps, such as a LICAP flap, lateral intercostal artery perforator flap. So we have a tumor in the upper outer quadrant, and then we use that tissue from here to fill up the gap over here in the upper outer quadrant. So the scope for the field in breast cancer itself is quite enormous. And now there are other scopes that we also now do is we also go for lymphedema. A lot of people sustain lymphedema, especially after radiotherapy, and for them we can do a lot of plastic surgical procedures. Here we have done a lymphovenous anastomosis, and so you can also do other procedures like vascularized lymph node transfers and liposuction, and we can to produce good results. And of course, when you keep doing this, we can also get other aesthetic procedures like breast reduction. So the scope of the field is quite a lot. The other thing that a lot of people keep asking is, when we all thought about doing oncoplastic breast surgery for myself, and a lot of people were discouraged when me saying that a lot of Indian women do not want a reconstruction. Breast reconstruction is not going to really take off, and a lot of other reasons. And if you're going to know all the reasons, you just need to keep telling people that you're going to do breast reconstruction. You will get all the reasons. But then what we did was that we conducted a survey among Indian women. We conducted a survey among 10,300 women. And a lot of course, they were not cancer patients, but we just wanted to know what generally Indian women wanted. Because, and what we found out was that around 48 percentage, which is just around 50-50, knew that breast could be reconstructed. So it was not a very alien topic. And 77 percentage felt that women do get depressed if they do not have any breast. And 76 percentage felt that women would like to undergo breast reconstruction if they had to undergo a mastectomy. So that means Indian women would like to go for breast reconstruction. And you can see that the Indian women have also changed over the years. The fashion, the clothing, and things have all changed. And with the era of the present clothing, a lot of people would find it very difficult to hide their breast, which is not there in the present clothing. I'll give an example of another woman. So we did a delayed breast reconstruction for a 31-year-old Tamil teacher. So she stopped going to work, and then she told that she would go to work only after her breasts were reconstructed, and then we reconstructed her breast. And this is what she has written in Tamil. And she has written, அன்றைய நாள் முதல் நான் மீண்டும் என் மார்பகம் எனக்கு மீண்டும் பழையபடி கிடைக்காதா என ஏங்கியதுண்டு. மற்ற பெண்களை பார்க்கும் போதும் மனம் வருந்ததும் ஒன்று. இன்று நான் மகிழ்ச்சியாக இருப்பதற்கு காரணமாக இருந்த அத்தனை நல்லுணங்களுக்கும் என் நெஞ்சார்ந்த நன்றியை தெரிவித்துக் கொள்கிறேன். It shows that a lot of people do want breast reconstruction, and if we can do it, I think we're going to fill a gap. So this is a graph that I took from a national comparative audit of mastectomy and breast reconstruction in UK. And if you can see this, it all denotes upon how many people were offered reconstruction and how many people undertook reconstruction, and they divided it according to the counties. And if you can see, it is quite high in Essex and is quite low in certain areas. And if you can think and see what is the reason behind all these areas, because England is a very small country and people can be too different from one place to the other. And if you can see, wherever the rates of reconstruction are high, there are good centers of breast reconstruction. So if you're going to have a lot of good centers of breast reconstruction and good breast centers, the amount of reconstruction rates are definitely going to be high. So which means that if we are going to offer it, definitely the rates are going to get better. Next, I would like to talk about these two terms: oncoplastic breast surgeon and breast reconstructive surgeon. Now, are these two terms synonymous? Well, they aren't synonymous. I've already explained about what oncoplastic breast surgeon means. An oncoplastic breast surgeon deals with both the breast oncology as well as the plastic surgical procedures of the breast. Well, a breast reconstructive surgeon means that they fill up the gap which is left behind the work done by a surgical oncologist or the breast surgeons after that they have completed the mastectomy or a partial or a breast conservative surgery. So these two terms are not synonymous. And I'd like to tell you, I would like to explain later as to why it is better to be a oncoplastic breast surgeon. So I'd like to, so this is one among the advice given to me by Dr. Subramania Iyer during a BRASCON meeting. And then he told me that if you want to do a lot of breast reconstruction, you must first be known as a breast surgeon amongst your colleagues and other specialties, which what he meant was like radiotherapy, medical oncology, pathology, and so on. You need not do the resection always, but you must know and must have done the oncological procedures few times. So that's, I think that's a great advice given by him. And those of you who have visited him will know Dr. Subramania is a great plastic surgeon, and he's got a very good, busy head and neck surgical unit. And if you can say, if you attend his SOP along with him, so when he attends his OPD, he does not see it only based on this oral malignancies, the reconstruction for oral malignancies. He sees all patients with oral cancers, and from there they also evaluate the patient, and then he talks about it, and then later he goes on for surgery. And you can see in this the procedures that he does. In certain cases where it is quite complicated, he comes on for the resection, but otherwise, mostly he goes on only for the reconstruction part, which he is more of, which he likes more and he does more. So that's what he told that we need to do. We need to also do a lot of breast oncology. And you can see from the Ganga trauma experience. So what we do is that in our hospital in 2018, of course, this is before COVID times, we've had a total of around 938 open limb injuries in lower limb of 702 and upper limb of 236 upper limb injuries. And if you can think and see as to why we got so much of open limb injuries, it is definitely not that only Coimbatore has got bad roads and bad driving. And it's not that we are the only ones who can do a particular form of a surgery. It is, I think it is more probably the system in which if a patient comes at 2 a.m., 3 a.m., whatever time it is, a senior plastic surgeon sees him, and the senior plastics, and because the senior plastic surgeon sees him, senior orthopedic surgeon sees him, what happens is that treatment gets better. A lot of people feel it better. And I think that is the reason why there's more amount of plastic surgical work in this. So it's basically it is about the bird which comes first gets the earliest worm. So now we're going to think in terms of a timeline of a patient with the breast cancer. So first they come for a consultation for a breast lump, and then they go for investigations like a mammogram, ultrasound, and then they do a biopsy. And then once they get the biopsy and it is proven cancer, they do a metastatic workup, and finally a plan is formed for them. And then either they get their surgery before or after chemotherapy. And then finally, the surgeon who actually consulted the patient for a breast lump, he actually forms the plan and he does the surgery. And depending upon what he says and whether he encourages or not encourages, now the breast reconstruction is done. And depending upon what he thinks is the best form of breast reconstruction, that is also done. So, and then in certain cases, if he or she feels that they would like to refer to a plastic surgeon, it gets done. But if you're going to think and see the number of people who are coming to this part, consultation for a breast lump, and the number of people who are coming at this part, the referral from a breast surgeon to a plastic surgeon, I'm sure a lot of people who are in this field will agree the number is very, very less. And there are a lot of ways, and there are so many reasons in which it gets filtered, the medical, non-medical reasons. But then there are so many things that which get filtered. On the other hand, so this is the place where a breast reconstructive surgeon comes. So I think what is the other hand that we need to do is that we need to become like an oncoplastic breast surgeons, where we start at this area, so consultation from a breast lump. I'm sure if we are going to go start from that area, I think we are going to ask, or of course we cannot force anyone for reconstruction, and reconstruction should be done and is only done only when the patient desires. Reconstruction is not something which is life-saving, and hence it should be done and only done only when the patient desires. But definitely, if we are going to offer it from the day number one, I'm sure a lot more patients will take it up and do it. And that is the reason what we're thinking of, why I feel that as plastic surgeons, we should also think about doing more of oncology. And the knowledge of cancer would be very beneficial as well, beneficial to us because for reconstruction as well, because we know whether the patient would need to go for radiotherapy, and that would base us on whether we need to go for whether we like to go for an implant or what type of reconstruction should we go to. And then we'll also know that suppose the patient needs to go for an adjuvant therapy, we need to get the wounds healing faster, and we need to send the patient to adjuvant therapy faster. So there are certain protocols and things that we will also keep changing when if you're going to do a lot if you're going to do if you're going to know cancer. The other thing is that if you're going to know cancer, of course, we will do things better, and of course, a lot of patients will have more confidence in us and will agree to reconstruction. And it's also essential that we need to do the full gamut of oncoplastic breast surgery. So, for example, in these cases, where I took all these cases from the internet, you can see that all these cases they've done a breast reconstructive surgery, and all for these in all these cases they would have needed some form of a volume replacement, which has not been done, and then it has come to these cases. So, if you see a lot of people, they do oncoplastic breast surgery, and then they know only a certain techniques, and then they don't know some certain techniques, they just fit in according to it, and then we get it. So we need to do the full gamut of oncoplastic breast surgery, from implants to pedicle flaps to microsurgical free flaps. Else we'll be only called for difficult cases or failed cases. So if we next think and see as to why do breast surgeons do oncoplasty, and sometimes a lot of us do get charged up or feel thoughtful about it. Well, if we can actually put ourselves in their shoes, then if you can actually see what breast surgery is about, it's quite simple in terms of surgery, in terms of mastectomy, breast conservative surgery, and excision biopsy. And then for axilla, they do an axial dissection or a sentinel lymph node biopsy. But then the real charm and the thing with for breast actually comes either in two main things. One is identifying smaller tumors, and the other thing is that, and also doing other thing is in oncoplastic surgery. So that's where they also modify themselves. They also they try to feel themselves better. That is where they try to feel among their colleagues and peers. They try to say that they are getting better. And it is basically, if you're looking into what Charles Darwin said, it's not the strongest of the species that survive, not the most intelligent, but rather the one most adaptable to change. And that's probably what they're doing, because with a lot of people that are doing this breast surgery, they wanted to feel and get themselves better, and that's why they're doing oncoplasty surgery. And in this scenario, I think as plastic surgeons also, I think we also would need to change a bit so that we will also be able to survive in this field. A lot of people keep thinking and often ask, are we plastic surgeons fit to do breast oncology? Because they say, a lot of people think that we are not fit to do because of the law. But by law, I think we will be yes if you have done MS or DNB general surgery. And most of us have done MS and DNB general surgery. And those of them who have done 6 years of plastic surgery, if you can see in the books, in the curriculum that has been prescribed, such as Graben-Smith, Nelligan, there is definitely a chapter on breast cancer. So I guess it should be okay for them as well. So by law, it should be okay. But having said that, it's just not enough if you do MS or DNB plastic surgery, because for a woman who comes to us, the patient mainly comes for proper cancer treatment. So that is actually the most important thing. Even in the word called oncoplastic surgery, onco comes first and then only comes plastic. So we need to do the onco part correctly, and we need to do it really well. If we cannot do it, if we're not doing it right, I think we should not do it. So we need to keep updated. So to just give you an example, I did my general surgery between 2008 to 2011 at Madras Medical College under Professor G. Shivkumar. At that time, we were not talking much about ductal carcinoma in situ. So when I went to UK, and that was the first time that I saw that there were a lady who was posted for mastectomy for a ductal carcinoma in situ. I was like thinking, what are they doing? So the things had changed. And so from what I was studying to what is now, I think a lot of things have quite changed. A lot of advancements have taken place, and we need to keep abreast with all these changes. So how to keep updated? I think today we are in a time where knowledge is in its explosion. Knowledge is available in so many areas. It is just that we need to pick it up and we need to take it up. It's unlike so many years before where I heard that people used to go hang around in libraries. Only few people had some articles and so on. So you can just read the NCCN guidelines. The NCCN guidelines tells you exactly what to do. There are a lot of books to do. I think we need to visit a lot of surgeons, and I would recommend a lot of people to become members of BRASA, the Breast Reconstructive and Aesthetic Surgery Group in India. It is basically a group which has been started by plastic surgeons, and they conduct a meeting called BRASCON every year. I think it is a very good meeting in the sense that it talks about breast reconstruction, it talks about aesthetic plastic surgery, it talks about breast oncology surgery, chemotherapy, radiotherapy, and so on. So I think for oncoplastic surgery, these type of meetings would be very good. And how to become, so if there's a young person who wants to become an oncoplastic breast surgeon, so how to become an oncoplastic breast surgeon? So there are two ways in which a person gets to become an oncoplastic breast surgeon. Some people start off after doing the general surgery, and they do breast surgery, and as they keep going on, they become they start doing some oncoplastic work. But I think the best way to do a good oncoplastic work would be to do is to after finishing the plastic surgical training. Presently in UK, those people who have finished their plastic surgery, they also some who want to specialize, they do 1 year or so in the oncology part, and then they get specialized in oncoplastic breast surgery. So why I say that it's best to do after plastic surgical training is because after plastic surgical training, you need to know, you need to have some microsurgical skills. You need to have a good understanding of the blood supply of the skin, blood supply of flaps, and you need to know, have some good aesthetic ideals and views about the breast. And all these things really do help. And of course, since you also finished your general surgery, you also have an idea about breast cancer and its management, which you needs to be sharpened up. And I think it is very essential that as soon as they finish their MCH or DMB, they need to work with another oncoplastic breast surgeon. I was very fortunate to work with my mentor, Professor Venkat Ramakrishnan, a great man. And I also worked with Mr. Griffiths, Ms. Morgan. I think that they were all great people in UK, from where I learned a lot. And then we also need to attend multidisciplinary meets. And from when you attend a lot of MDT meets, you also gain to know, start learning more. And then we also, you need to assist the breast surgeons. So when we were there in UK, so there were two fellows who would go along. So one fellow will go along for the flap raising part and the closing part of the abdomen. The other person would go along with the breast surgeon. We would do the breast surgery, and then we would take the pedicle and plumb the vessels. So that was what we used to do. So I think it is essential that we assist breast surgeons as well. When we keep assisting, we do learn a lot. When we were in UK, there were a lot of online courses which we enrolled for. Any sort of place where you can learn for, you need to do it, and then you need to learn all techniques. And then once I came back to India, I want to know how the local scenario was, and I wanted the feel of Indian women. So I learned from Dr. Selvi Radhakrishna. I learned how to do some ultrasound guided biopsies, how to read a mammogram, how to do an ultrasound, and so on. The other important thing is that you need to treat benign breast diseases. I just like to take a cue from what is happening in Ganga. So a lot of people come to Ganga and ask my father how to do a lot of replants. And he would say that if you want to do a lot of replants, you need to do 30 to 50 fingertip injuries really well. When you do all of them really well, one replant will come. And you keep doing all of them well, you get more replants. And I think having come back, what I feel is that it is the same for breast surgery as well. I think instead of fingertip injuries, it's about benign breast diseases, screening for breast cancer, talking to a lot of women about breast pain, benign breast lumps, nipple discharges, lactation lapses, and so on. I think we need to keep doing all these also, and only then when you get to do around 20 to 30 of these cases, you get one cancer, and when you get 2 or 3 of those cancers, one goes for reconstruction. I think that's how it works. I'm sure a lot of people are going to thinking that what these people, he's only talking about plastic surgeon needs to do cancer, and isn't teamwork better? I think definitely teamwork is better, but we must be in the front of the team and not be an also part of the team. I think that is important. So how teamwork is better? So initially we were, if, for example, if we're going to do a DF flap, we were having 2 teams. So I would do the mastectomy. I would raise the flap and close the abdomen, and then the other team led by my father, Dr. Asbabdi, and Hari sir, you used to take the vessels down, and then they used to anastomose the vessels. And now we have also added our surgical oncologist. Now we have 3 teams. Now this is helps makes it even better. It shortens the time of surgery because he does the mastectomy, and then I'm only for the raising, closing the abdomen, and my father and Dr. Hari sir help to anastomose the vessels. The other thing is that the oncologist sometimes when he finishes his mastectomy, he also harvests the thoracodorsal vessels, which helps. And for our BRCA patients, he helps also in doing a salpingo-oophorectomy. So that's how he helps us. And because we are also with him, we help to guide and to placing our incisions better, and we get better results. And so we have also been using ICG for lymphedema, and now we are also been using it for sentinel lymph node biopsy. So their work also gets better. So as a teamwork, everyone seems to get better. So this is my last slide. So as a remember, there's a great scope in this field. A lot of women want breast reconstruction, and as plastic surgeons, we need to learn oncology as well, and we need to stay updated. And we need to be the point of first contact. But it can be a slowly growing field, but I'm sure it's definitely a surely growing field. Thank you.
Thanks, thanks, Raja, for that broad overview. I'm sure for a lot of youngsters coming on and looking at this confusing picture, particularly in the Indian scenario. Am I heard?
Yes, sir.
Can you hear me?
Yes, sir. We can hear you, sir.
Yeah, particularly in the Indian scenario where a lot of things are different and people seeking for directions. Raja has given a broad overview of the gamut. You would rather put it as what is the role of the plastic surgeon in the woman with the breast cancer. And he has touched, obviously it's a very large topic. It's both cancer, lymphedema, post-resection deformity, symmetry, etc., etc. And it will take a whole conference to kind of even give an introduction. But good, Raja, good that you started. And I'm sure there are lots and lots of questions. Some of the questions that have come through the chat, the most important and the most obvious questions are we getting into a field completely new where we are really not trained, where we'll never be trained, namely doing an oncological resection. This is not like a BCC or an SCC in the skin. This is an oncological resection. It is not just like a mastectomy. You need to be aware of the various types of breast cancer, the prognosis, who gets adjuvant, who gets neoadjuvant, anterior, posterior, etc., etc. We need to know the whole gamut. Or are you much better working with a team which does that with the borders clearly defined?
So I think we just need to understand it. We need to learn it, and once you start learning it, it's not something very difficult. So if you actually see a lot of people, if you is learning reconstruction more difficult, or if you said learning oncology more difficult, I'm sure all of us will agree that learning all these flaps is more difficult. So when people are learning all these flaps and then they are also progressing, it's quite, if we can just read it, I'm sure we can definitely learn it. So it's not very difficult, and all these procedures are not very difficult at all. And once you start doing it, and once you start working with people, you can easily do it. So that's about it. And so that I also told that it's always good to work as a team. And what I mean, even when you're working as a team, you should be a frontline member. You should have seen the patient first. I think that is what I want to convey repeatedly. And you should be the first, and you should form the guidelines on what you're going to do for plan for the treatment.
Thanks, Raja. Karthik, do we have 2 more minutes or?
Yes, sir. You have about 10 minutes, sir.
Okay, excellent. I will be waiting for some more questions to come. I want to make 2 or 3 points which I am very clear about. As far as breast reconstruction in our country is concerned, one has to understand a few important caveats which do not apply to a lot of societies, a lot of different. For example, you cannot directly compare UK and here. There is something called end user paying, there is something called insurance, and there is something called private. Now, we do large extent in our country, 70% of it is private. So, which means out of pocket. Now, that is changing. Hopefully, in about 15-20 years' time, it's changing to an extent that a large 40 to 50% of it will be dealt with by insurance. When that happens, now I'm not even getting into whether somebody can afford it, but when that insurance happens, I have had the running battle with the insurance companies again. The current batch should be in a position to convince the insurance companies that the loss of a breast in a woman is as important, as devastating as, say, a loss of a pinna. Why am I saying this? The constant answer that I got is a reconstruction of breast is cosmetic, whereas a reconstruction of something else is not. For example, a reconstruction of the pinna is cosmetic as well. There is no function at all. A reconstruction knows, for that example, for that matter, is cosmetic. But all insurance companies will pay for a pinna. They'll pay for putting an implant after orchidectomy. They'll pay for nose reconstruction. They will not pay for breast. Now it is up to us to convince them that this is as important to the woman. Simple surveys should lead on to more complete, comprehensive surveys to prove that not only are they devastated, that they can be productive and much better if they have this done. That is one. Secondly, we should prove that the results are good enough to convince both the patients and the persons who refer them to you. It is not enough if we just keep saying, oh, we should do it, and so on. We should tell others how good our results are, and it should be seen as important. Karthik, can I just share the screen for a minute?
Yes, sir. Yes, sir. Please go ahead.
Okay. Now, I'm just showing you something here. It is not, as Raja and others keep saying, it is not like the kind of apps that you do, it is how you do something that is more important. For example, even a simple LD in a patient. See this. Anybody, all your oncologists will be able to resect this and then put an LD. This is not important at all. But to get an LD to go and stay and achieve a kind of shape, you need a bit of training. You need to have a bit of three-dimensional thinking, and so that you can give a better result and convince them that your results are far better than their results. Sorry, I seem to have been lost here.
We're not able to see your picture, sir.
Did you not see the screen when I shared the?
No, we can't see your screen, sir.
I thought we were sharing the screen.
You have to press the share screen underneath, sir. There's a green button.
I seem to have lost the thing.
If you move your cursor, you'll get a green button underneath, sir. That is share screen.
1 second. Yeah, okay. Yeah. All right. Can you see it now?
No, sir.
Not yet.
Can you see it now?
Yes, just starting.
Yeah, I would bother with the full screen. Can you just see this four pictures here?
Yes,
of
sir.
a resection. Now, this is not a fancy flap. This is not a great complex thing. This is something we do for bread and butter for a living. A simple LD taken from one side and put in. But the way you do it, the way you achieve the contour, the way you turn it around, all that you draw from your extensive experience of flap biology, flap behavior, scar behavior, etc., to give a good result. And that is really what we want. And that is what we want to tell others, that that we do something better than they. And that is what is more important. Okay. How am I getting this, Karthik?
You want to take it off?
I'm not able to get back into the...
Oh, I'll take it off. I'll take it off.
Yeah, okay, back here. So you should be doing it better. You should convince the insurance companies that is very important, which means you need hard evidence, solid scientific backed evidence. Three, you must convince the guys who are referring the cases to you. There is a big difference, Raja, between having finger replants and fingertips walking into your door. The 99.99, well, I'll say 100% of breast reconstruction are elective. They will talk to various people before they come to you.
Yes, sir.
And this is a crucial difference, which means you need to set yourself up for that. We need to make sure that people know that we are delivering something better. And that is where this thing comes commonly. All right, having said that, I think, Karthik, I'm done. If anybody wants to ask more questions, somebody wants to know what is the role of robotics in breast surgery, Raja. Any experience?
Sir, people have the thing about robotics is that now and then people do sort of robotics. They've used robotics for harvesting LT by flap, but things are not very common in robotics for breast surgery. The reason being it is quite external. Since it is quite external, so it is not. They don't find it as a big difference in the outcomes between doing normally and not normally. So still, it's in its infancy. But probably things may change.
Okay, thank you. And just like I mentioned earlier, Aditya and several others on the chat screen have told me that a lot of us work in corporate setups and semi-corporate setups, quasi-corporate setups, where it's very important to take everybody along, and where the borders sometimes are very, very clearly defined, and it's very important not to step on each other's toes. So if you're in a setup where the borders are clearly defined, make sure you take them along rather than trying to kind of say, I want to do this, I want to do yours as well. So that is very important. That is Aditya's message.
One Dr. Ashok has raised his hand. Dr. Ashok, can you unmute yourself and ask the question to Dr. Shivram?
Yeah, go ahead. Straight away ask. Unmute yourself and ask.
Yeah. It was as you put out the whole gamut of surgeries were covered. My question is, you have done so successfully in Ganga between ortho and plastic surgery, a beautiful combination work. When you have such a successful combined work, why can't you suggest doing same thing? Doing a plastic surgeon doing oncology work, getting to see these oncology patients would be too much of an ask. When you have you can actually replicate what you have done with ortho plastic, similarly oncoplastic work. Why would you suggest plastic surgeon do all the work as you suggested? I just want to know his thinking there.
Sir, I think the relationship between the ortho and plastic have been started from 1991, so it's been a long time. So we're just now trying to start it. So we also have a surgical oncologist, and with us as shown to you in the picture. And what we do is that every case that we go, both of us see together, and I think it really makes a big difference when you see together. So he also shares what he thinks. I also share what I think, and finally we come and say, okay, let's do this, and then we talk straight to the patient. I think it's just working well as of now. Even if it is just for a small breast pain, we do our clinics together, sir. So I hope we become successful in this, and we just a start, sir. So we are very small now. We are just a start, and hope to get better.
Well done, Raja. If there are no more questions, I will hand it back to Karthik.
Can I ask a question?
Please do, Karthik.
Now, he was talking about the cooperation and the plastic surgeon being there along with the onco surgeon, seeing the patient and discussing the possibilities and modalities along with the onco surgeon. That is accepted. Now, I think Dr. Ashok also wanted to ask that whether it is accepted or whether it is ideal for the plastic surgeon to do the onco work. That is the question. Participating in the team is okay, participating in the surgery is okay, but doing the onco part of the work by the plastic surgeon, that is, I don't know, I'm not very clear on that. Is it okay for the plastic surgeon? Will it be better?
Are you commenting or asking?
I just want to know. I want to know what because they've done a lot of work in their institution.
Sir, it all depends upon whether we are trained or not. So that we also told that we need to be trained in it. If you're trained in it, if you've done it, then you just go ahead and do it. Yeah, because, so for example, when we were in UK, so every time, so for the first surgery, we will go to the abdomen and I'll be in the breast. The next surgery, I will go to the abdomen, the next fellow will go to the breast. So the number of times I've been using a DF, I've done the same number of times doing the mastectomy also. I have done the same number of times doing the resection part also. So since we are trained so many times, I think we should we can go ahead and do it. But you should do it properly.
That's there. That's there. And again, Dr. Arush and Dr. Ashok have raised their hands again. Dr. Shivram.
Yeah, can I ask it straight away instead of typing it? Because I haven't seen any type chat here. Can you straight away ask, please? And also one question. Please don't comment. Just ask questions.
Sir, I am a fresh general surgery passed out. I am wanting to know what sort of learning curve are we looking at to become a oncoplastic breast surgeon, sir?
Okay, sir. So I think, as I told earlier, that we need to work with an oncoplastic breast surgeon. I think people who got a lot of volumes, and once you start going along with them, you work with a person who has got good enough volumes. Then you start learning, and then you will get it. The thing about it is that for doing a DF flaps, I think the DF flaps are all perforator-based free flaps. So I think basically you should have done some amount of normal microsurgery, say for example aggressor free flap or some other free flap before you graduate onto DF flaps and perforator-based free flaps. So there is a curve, but once done, it should be fine.
Okay, can I just add to that? We must all remember that Raja is drawing from his experience in a place where the training, when you get into a stream of higher surgical training, you sort of define your contours very early on. When you define your contours very early on for an oncoplastic program, you would be taken through the various modalities in that, you'll be taken through the various nuances. But in our country, the training program, as you all know, is pretty much broad-based. You'll do hand, you'll do burns, you'll do everything, and then you'll come out. Now, if you're still interested at the end of it, the way I see at least developing in the next 50, 60 years is you would be developing it as a special passionate interest after you finish your basic plastic surgical training, and then you will have to undergo further bit of training in that, not as a part of, you're not going to have an MCH plastic surgery brackets breast oncoplasty, not for the near future. So it's going to take a long time. Any other questions?
There is one question in the chat box, sir.
Yeah, I saw that. I saw that Anu was asking the same question in a slightly different way. If you start asking, if you start doing cancer resection, how can you keep a breast? It's the same thing. See, in an oncoplastic breast surgery program, which takes about 2 to 4 years in the UK, you will be attending oncology workshops. You will be attending oncology conferences. You will be attending how to do hands-on demos, videos, etc. department meeting, which includes surgical oncology, medical oncology, radiation oncology, and so on. In an average MCH or even a 6-year DNB program or a 3-year post-MS DNB program, you will not be attending almost virtually most of it. Now, if you want to do it, you'll have to do it separately, which is basically what the answer to that question is. If you want to keep a breast and you want to be a really good kind of person, it is not just about doing a mastectomy. Anybody can do a mastectomy. That is not the thing at all. You must remember, surgery is not just about the technique. It's about having to handle the entire gamut. So that is very, very important that we don't get away thinking, if I know how to do an operation, I know how to deal with the patient having the particular problem. No, it's not. It's much more than that, which is why you need the training.
Okay, sir.
Thanks, Karthik. Thanks very much for putting this. I know a lot of controversies here, but that will take a lot of. I can see Dr. Shivra smiling there. And
I just want to chip in here. Only one small comment fast.
Yes, sir.
I think she has done extremely well the delivery of the talk. I'm really happy about it. There was a vast difference between this talk and the similar talk which he gave in APSICON before. So much of improvement is there in his delivery, number one. Number two, I would like to tell this aspect of it. All of us are plastic surgeons, but only some can do brachial plexus. All of us are plastic surgeons, only some do onco reconstruction. So it is all depends upon your interest and passion, which you have got to develop, number one. Second thing is plastic surgery is something which is a locally acceptable specialty. In Apollo, you do something else. In Ganga, you do something else because it is the requirement of the local requirement to which you have to adapt yourself to. In Coimbatore, Ganga is recognized as a very great institution. So if you say that we also do breast, they will come. But in our setup, it is a different ball game. But we will also have to develop our attitude toward developing your interest. That is all. I think it is a local requirement, adaptability to the local situation and your passion put together. I think you can do anything. Head and neck, Subramania Iyer does everything in head and neck. Not necessarily he must do resection. Same thing, I think one of these days, Raja Shanmugam will start doing resection also and people will start coming. And they may not come to me for that. I may do more of diabetic foot. So I think it is an adaptability. Our specialty is something with the most adaptable specialty. I think we can have our own niche, whichever way we want it to. I think it is pliable. I think it is all the way we molded our specialty. Thank you. Sorry to take your time.
No, thank you, sir. That is so
Thank
true.
you, sir.
That is so true. It is so true. Thanks, Karthik. Hand the mic back to you.